So as you know, this live episode that we do is a Q&A. Please understand that this does not in any way constitute a patient-doctor relationship, even if some of you may be our patients. This is in no way should be construed as medical advice or any kind of medical guidance. This is for informational and educational purposes only, so please understand that. And then please be sure that you are muted until you want to ask a question. Otherwise, there's a lot of sound that we hear in the background sound that can sometimes be disturbing when we repost this episode. So it can sometimes make the sound not all that pleasant for people to listen to. And the other thing that happens is that if you have any sound from your environment and you're not muted, then your picture comes up on the screen. And so not everyone always wants to be seen on the screen because we do post this video to our Patreon podcast page. So we don't want to reveal reveal who you are, and we obviously don't want any disturbance in the sound quality of the episode itself. So for that reason, please keep yourself muted until or unless you want to ask a question. So we will get started. And so we had a lot of questions posted to our Patreon page. And in the past, we've had some complaints that when we do these live episodes, we tend to just answer the questions to the people who have attended. And we recognize that not everyone can attend, which is why they post the questions. And so we're going to try to go back and forth just to try to satisfy everyone. We do the best we can in trying to cover all the questions. But I do want to add that we get a lot of great topics from the questions themselves. So if we don't get to every question, please know that we've read them all, and that we usually put them on our topic list and we'll address them at some point in one of the podcasts in the near future for sure. So, but we will try our best. So Dr. Kaufman, do you want to add anything to what I've just rambled on about?
No, you did a great job.
Okay. So, all right, so where should we begin? So there are also now questions in the chat. So we can start with the chat box. And then we can go to the Patreon page. And then, of course, if you have a question you want to ask live, please just raise your hand and we will pick on you. So, all right. So the first question that was posted was, in dysautonomia, are there alternatives to beta blockers if metoprolol does not appropriately balance blood pressure and tachycardia, i.e. heart rate spikes with hypotension, and what might cause tachycardia in dysautonomia after being under control for years? Mast cell activation syndrome, COVID vaccination, microclots, uncontrolled hypothyroidism. I mean, I think we probably all of the above.
All of the above.
It's certainly a cause. I mean, so very often, actually, you think that the pot's under control, but then something, of course, will trigger it. And Kathy definitely listed a lot of very good ideas of what could potentially be a trigger for a recurrence of the tachycardia and dysautonomia. And there are a lot of other treatments other than beta blockers. In fact, beta blockers, in my experience at least, and Dr. Kaufman, you can say if this is not your experience, and I think we've talked about this in one of the podcasts, I think they work for a short period of time, but they very often lose their efficacy.
Yeah, I'm going to say it a different way. Beta blockers definitely can work. I mean, the real question is, what's the cause? And we don't always know, and the cause changes. I think that's part of the importance of this question, that what provokes an inappropriate tachycardia, which we can call POTS in quotes, because it doesn't necessarily fit the exact definition of POTS. So there can be many different reasons for that, and beta blockers can slow the heart rate down in low doses effectively. But I increasingly see patients who appear reasonably, these are patients with dysautonomia, who appear reasonably well controlled with, say, beta blockers and volume expansion, but then lose control, or I lose control, we lose control. And it seems to morph from into a more typical hyperadrenergic POTS picture. And then I switched medications to usually guanfacine. And I've seen it so repeatedly that I am increasingly starting with guanfacine, even if the numbers don't look hyperadrenergic. And it's a really interesting change for me in my approach, supported, I think, by the outcome, but also some things I've heard from other neurologists, as well as this whole discussion in our masterminds on pelvic vein compression syndromes.
Yeah.
So it's a really interesting topic.
Yeah, I completely agree. I actually have been using beta blockers less and less over time, unless their resting heart rate is extraordinarily high and they're symptomatic. I think, importantly, I think symptomatic tachycardia or even symptomatic bradycardia, which is a whole other topic, of course. Um, if it's symptomatic, it's something that needs to be addressed and treated for sure. And POTS itself is often symptomatic, but when there's a resting heart rate that's too high, I will consider using beta blockers. But if the resting heart rate is within the normal range or just mildly elevated, and they aren't reporting great, concerning symptoms at rest, but when they stand or when they move, their heart rate goes disproportionately elevated, I will consider a low dose of a beta blocker, but I have been increasingly not using beta blockers, is what I'm saying. And I'm finding them that they could be useful for a short period of time, but then they lose their efficacy, and then we have to go to other medications. I've been using more vasopressors, but I will also add that I've been using Corlinor a lot more lately because I find that its mechanism of action, which is more electrical in nature, um, is much more effective for patients with POTS. And so I sometimes start with Corlinor. I used to, do that as like a third line treatment, but now it's become some of my first line treatment options for
Right.
patients.
I would start with Colonor if I could get it. I
Yeah,
mean, getting it approved is
right.
up there with Xifaxan and Motegrity. It's very
Yeah, I
difficult.
spend a lot of time on the phone with insurance companies. It's really quite
Yeah.
annoying. I agree with you, but if we take the insurance barrier out of the equation, I find that when I can get a patient on Corlinor, it's actually very effective. But I've been using more vasopressors. I definitely like midodrine. I like fludrocortisone. Um, and I like, I think volume expansion has been shown to be very, very helpful. And I think that was actually one of the questions that was posted that I saw, which talked about um, uh, treatment for POTS with regard to IVIG. And then I know that there was a recent conversation on the masterminds with regards to albumin for volume expansion.
Which
And
is IVIG.
yeah, and I don't know, do you think that POTS has an autoimmune etiology?
I do definitely think some cohort of patients have an autoimmune etiology.
Or
I'm
specifically
convinced
POTS?
of it.
For POTS, I mean,
But
for basic POTS definition,
yes,
you think
yes,
that there's an autoimmune? Okay.
yeah. I mean, how else explain a viral, forget about COVID, forget about ME/CFS and long COVID. How else explain the classic story of viral illness followed by POTS? I mean, that's historic. That's
Right. So
everything we're talking about.
I agree, but I guess that begs the question then, do we think that everything that's post-viral is autoimmune?
Well, no, not everything, but
Right. Well,
I
that's
think we can't ignore that some of this is autoimmune, some group of patients. I mean, I know a lot of our colleagues don't believe in the cell trend panel of antibodies. I continue to find them useful.
yeah.
And they're very abnormal in a significant portion of those patients. And they come from somewhere.
Right. Right. And I guess also I can't help but sort of struggle. And I guess these are my own questions as opposed to everyone else's questions, but these are the questions that are constantly in my head. So there's a specific definition for autoimmune, and it doesn't necessarily mean that if it's something is not autoimmune, it doesn't mean there is not immune dysregulation.
Absolutely right. I
Right.
agree.
So that's what I struggle with. So is this truly an autoimmune concern, or is this just an immune system that's gone awry kind of thing? That's what I struggle with, right? So, which is why, as you know, I use a lot of immunomodulatory therapies. It's not just about an autoimmune approach, though. It's about just trying to control the immune response in general. And as we know, and we've talked about this on our one of our podcasts, I mean, take the mast cells, which is the part of the innate immune system. They release these enzymes that break down connective tissue. And so I always wonder, how much is the connective tissue playing a role in this? It actually weakens the vessel walls. I mean, the outer lining of those vessels are all connective tissue,
Right.
right? So if you have compromised vessels, then we can extrapolate perhaps and decide that there are compromised baroreceptors and chemoreceptors, which control how the vessels will respond to changes of volume and pressure. And then you have a whole other set of things to potentially target for treatment with regards to any kind of autonomic dysfunction. And so anyway, so these are this is what
Well,
keeps
I mean,
me awake at night.
everything you're saying just said drives home what we say on the podcast all the time, which is all of these pathologies are interacting
Right.
and working systemically. We're not just seeing a single organ system dysfunctional. It's all systemic. And yes, I do think at the root of those systemic bidirectional interactions is a disturbed immune system. I agree with you. I want to go back to the original question for a minute. So I think volume expansion gets lost too frequently in the initial treatment, and increasingly that is my first step. I think it makes a lot of sense. We know in ME/CFS patients that they are generally volume depleted, although we don't exactly know why. And we know that volume depletion will lead to a compensatory appropriate tachycardia, right? That's when you stand up. If you're healthy, your heart rate goes up to make up for gravity until there's a constriction mechanisms kick in. So volume expansion will help that. It doesn't cure POTS, but it should make it much more easy to manage, and it should improve perfusion, because at the end of the day, the whole downstream effect of POTS is hypoperfusion to brain and organs.
Right.
And I would caution on something you said, Eileen, in terms of tachycardia, that if the patient has no symptoms, maybe we don't have to go after it so aggressively. I would just want to make sure that we understand what symptoms can be caused, and take a very careful history. So I've met so many dozens of patients who say, well, I don't have dizziness when I stand up, so it's not POTS, that's not the problem. And yet they stand up and their heart rate goes to 130 and their blood pressure responds inappropriately, and they are hypoperfusing, but they don't get dizzy, and they have other problems from it. So it's important to understand.
Just to clarify, I was saying that they're not symptomatic at rest and their heart rate isn't like 140 at rest, right? So, I've had lots of patients who at rest, their heart rate is 100, 110, but they don't report any symptoms. And I do go through the list of what could potentially be a potential symptom. But regardless of whether when they stand and their heart rate goes up, as you know, the criteria says 30 beats per minute, but I don't stick to that rigid criteria. But if whether or not they have symptoms or not, I treat that. I definitely treat that. It's only at rest that I say that when we were specifically referring to beta blockers, that's what I was referring to. I don't throw beta blockers just because they have an elevated heart rate when they're sitting.
I agree. But I would want to know why they have that elevated heart rate. It's clearly abnormal. So.
Right. And so, and to answer the second part of the question, we very often see where POTS has been managed well, and their heart rates are, within the normal range, and they don't have any symptoms. And then all of a sudden things are out of control again. And it usually is because something has triggered it. And it's usually some exposure, which, by the way, can be endogenous or exogenous. So yes, vaccines, infection, but even stress to the body, whether it's, a metabolic disorder, it could anything, hypothyroidism. I think it was the hypothyroidism. Yeah. So
it could be a very simple thing.
Yeah, it could be very.
I mean, it can be travel.
Travel.
Patient feels well enough to go on a vacation, travel, and inevitably they don't keep up with their fluid intake.
That's right.
And they sweat more because they're more active. Bam, their fluid volume depleted.
Or even like a string of bad night's sleep, in a row. I mean, it could send a body into a stressful kind of response. And anytime the adrenal glands are provoked to sort of release some of their hormones, that too can send the body out of balance. And so if you have an underlying dysautonomia, then that could be triggered easily by that. So we see that all the time. So that's a good question. So I guess we should go to the page. Do you have the page open in front of you, Dave?
Well,
I have it. There's lots of questions here. I don't even know where to begin.
Yeah, I looked at some of them before we started. I mean, some of them are really complicated questions, long.
Yeah, they're long. I mean, some of these are just true podcast topics. But so I think this question was asked a couple of times. What is the initial workup when seeing an ME or LC? So myalgic encephalomyelitis or long COVID patient for the first time if patient can't afford all the labs. That's an interesting question, I thought. And actually, there was a similar question with regards to patients coming from Canada. Like, what is our initial workup? It's sort of in the same sort of, boxes. Like, what is the initial workup, and what can a patient do if they can't afford the things that we do? Which I think are good questions, because we order a lot of labs, a lot of labs. And oftentimes insurance companies don't want to cover all of the labs. And, I'm regularly adding diagnoses codes just so insurance will cover it. But obviously patients from Canada don't have, so they're paying out of pocket for those labs.
I think we should separate it into two groups.
Okay.
So, So let's do the US patients first. And let's assume that we're discussing American patients with health insurance, such as that is. My experience in general is that, and I get the weirdest thing looking at me on my screen.
I know, is it that mouse?
Yeah.
Or
Who is that mouse?
I know it just says Zoom user, but I put it on mute so that if there's a sound, you won't see that mouse anymore.
All right. So in general, I find all of the labs, with a few exceptions, are covered by all of the US health insurance companies, with the following exceptions. If it's Medicare, which generally is great, you have to have better codes. You can't, that's one of the areas where Medicare is difficult. You have to make sure there's good codes, and that requires lots of codes and bending the rules and cutting corners, et cetera. The latest scam I've seen from health insurance companies, and it's a tough one, is that putting into their policy that if your doctor is not in the healthcare network, the labs ordered by that doctor will not be covered. Now, that never used to be the case, except in some very strict HMO type networks. And so the patient, I routinely now ask the patient, please make sure that everything I order will be covered, or does it have to come from an in-network doctor? If it comes from the in-network doctor, the patient usually has somebody willing to cooperate, but it 2/3 of the time gets screwed up because either the doctor doesn't understand my labs or doesn't think they all should be done, or worst case scenario, this is the nightmare of nightmares. The patient goes to a local hospital to get the labs done, and they screw everything up, and then they never sent me the results. So that's happening more often, but in general, most labs are covered. That includes patients with Medicare, Medicaid. Kaiser is a problem. Kaiser is a nightmare. And usually they won't cover anything unless it's done in the Kaiser lab. None of what I just said, and you know this, applies to any of the so-called kits, which are from specialty labs. Like if somebody does tick-borne disease testing at an outside lab, that's usually not going to be covered. You know, those kinds of things are difficult. Canada. I love my Canadian patients,
Oh
but
my, so do I.
I don't think they
So hard though to
understand.
get things done. I know.
It's literally twice as much work for me, twice as much, because I have to pick and choose the labs. Then they go to their PCP in Canada. The PCP says, I'll help you, but they can't order the labs. So then they come back to me and we pick and choose the labs. Getting imaging done is ridiculous. It's so difficult. So Canadian patients are very difficult. It's really hard. The patients are great, but the system, it's that time when a single payer system completely works against the complex illness patient. And I've seen this in my UK patients and in my European and German patients. The healthcare system is great if you have a heart attack or a stroke or a sore throat or a kid, a baby. But if you have a complex illness, you are screwed.
Mm-hmm.
End of rant.
And it doesn't only apply to the labs, it applies to the imaging even. Trying to get the imaging done that is necessary is close to impossible. And that sort of segues into, there was other questions with regards to what are the appropriate imaging that we recommend for a consideration of, you know, things like CCI or any kind of connective tissue involvement. And in Canada, you know, you can get an MRI that's supine of the cervical spine, but I can't get anyone to order it for them, and I can't order it in Canada. So
and if you do get somebody, it can take 3 to 4 months to get it done, or longer.
Right. At least, I mean, I have patients waiting. We're told like in a year. So
Right.
Canada is just particularly problematic. And Kaiser here in California, at least, is just as problematic. So.
Right.
So it's not, yeah, so it's also across the border. But just to answer the question that was posted somewhere about what imaging we recommend. So I think this question comes up a lot, and I don't know why, because I don't think it's that confusing. An MRI cervical spine supine is the first thing that should be done. It's
Without contrast.
without
No
contrast,
contrast.
right? So it's a fairly easy and usually easy to get approved imaging study. And it's really all that we need to start to do the evaluation for CCI. People often ask me about upright, flexion, extension, all of which can sort of help in some aspects, but they're on the 1.5 Tesla, so the resolution is not as great. The bony landmarks or even the soft tissue landmarks that I need to do the measurements are not as clear. So the supine MRI actually makes it much easier to do the measurements, frankly. And you can see a lot more. Like you could see the posterior fossa, you can sort of see where it sits. And so that is where we always start. And I feel like there's just so much confusion out there.
This is a unfortunate example of the internet chat groups, forums, blogs, Facebook spaces working against our patients, because it seems to me every new patient I get when imaging comes up, they say, well, I was told I have to do an upright flex X, and I was going to say waste, but that's not a fair way to say it. I have to again spend time saying, no, that's not correct. We do the supine cervical MRI. Right. I don't know why that's the party line online, but it is.
I think because the visual is better for, like, I think people, when you look at the flexion extension, they can more appreciate visually what the instability is doing to the anatomy, but you don't need that to confirm CCI. And it's harder to get, frankly.
It has risk.
And it has risk. Exactly.
Patients have pain after those procedures.
They definitely
often have lingering or.
That's what I was about to say. Absolutely. No, don't be sorry. I'm glad that, because otherwise I just ramble, So, that's exactly what, if you have severe CCI, flexion and extension is not the most, safe positions for you. And in fact, I won't recommend a home traction trial until I've seen an MRI of your cervical spine, because I want to make sure it would be safe for you to put yourself in traction at home outside of the medical setting, right? Because you sort of never know what I'm going to see on the MRI. And I mean, to be fair, I rarely see anything that makes me think it's not safe, but sometimes the measurements are so abnormal that I think, oh, you just need to go right to ICT. Do not try home traction trial. Don't stop. Go past go, whatever that monopoly saying is.
Yeah. I'm maybe a little bit more of a cowboy. I do start traction this without MRI. I've never had a problem. The only time I wouldn't is if I've examined the patient and I do my in-office compression and traction and something happens. I mean, they're significantly symptomatic, then I'm not going to do it without the MRI.
Well, I mean, at least you assess them first, though. So maybe not radiographically as I do, but at least you assess them. So, and I think that's important.
Let me jump back to the question on labs for a second, maybe we can use this Zoom as a forum to discuss something which I think would be helpful. And I realize many of the people listening are actually already patients of mine or yours, but you all probably know people. So here's a suggestion. If a patient is going to be a new patient with a diagnosis or a suspected diagnosis of ME/CFS and long COVID or complex illness, I would urge that patient before they come to the office to spend some time finding out the following questions. Does their insurance cover an out-of-network doctor's orders? What is their insurance's in-network labs, Quest, LabCorp, other? What is their insurance's imaging vendor? That's the intermediary who gets paid to prevent you from getting images. That's how the insurance company works. You need to find out who that is, because if a prior auth is required, we need that information. I guess those are the three main things. And it may sound like little stuff, but those three things can add days to weeks of delay in getting stuff done and getting workups done.
Yeah, no, that was good advice. I thank you for saying that and laying that out for them, because I'm often saying that within the appointment. So I think this helps actually sort of spread the appropriate information around. Yeah, I mean, we've often been accused of ordering too many labs. So, but there are reasons. Yeah, I mean, there's reasons behind our madness, right? So we're trying to get as much data points so we can tailor our treatment so that we can better help patients, because, I think that the chronic and complex presentations, if we can find something that will help lead us towards the right, at least initial treatment plan that has the highest potential to be of benefit, that's obviously what we want to do. So that's what's behind the madness to our labs. And once you understand things like mast cell activation, frankly, then you can understand the sheer volume of labs that we sort of need to order to try to confirm or negate, or at least support other diagnoses that could be associated. So anyway, so I thank you for saying all of that, David. So, all right. So the next question, which I thought was an interesting one, can venous sinus stenosis be a cause of dysautonomia? If so, what might the mechanism be? Do you see dysautonomia symptoms improve after stenting? 100% I see it. So yes, venous sinus stenosis is a cause of dysautonomia, and I only know that because when it's corrected, a lot of the symptoms improve. So what is the mechanism of action behind that? I've given that a lot of thought, and to be fair, no one really knows specifically, but if you have stenosis, which technically is a compression and therefore an impediment to flow, then you have congestion that, so blood, and specifically, if we're referring to the venous sinuses, obviously, the fluid, I've said this before on podcasts, so I apologize if some of our listeners feel like I'm repeating myself, but I think these things are worth repeating sometimes. But people don't recognize that there is exchange between the volume compartments of the brain. So in other words, the arterial system, the venous system, and the CSF compartments, and actually that is how the glymphatic system works. There is exchange of fluid. And so if one compartment is congested, it affects the others. So of course, if there's venous stenosis, it backs up obviously into the arterial system, but that then affects the cerebral spinal fluid flow. So now you have just sort of congestion of all these fluid compartments, and then you could potentially have things like elevated intracranial pressure, which we also know can potentially be a cause of dysautonomia, just because of compression of neural tissue. And anytime you have involvement of neural tissue, then you have the potential of having nuclei involved that then contributes to autonomic dysfunction. And similarly, just along the lines of just overflow, and then hence because there's lack of appropriate flow, there's also hypovolemia. We're back to this idea that the vessels are sort of they're not receiving the appropriate messaging to have the appropriate response, is sort of the best way I can describe it. And so therefore you lead to, aberrant constriction and dilation at inappropriate times. So it can contribute to symptoms of dysautonomia. And these are the conversations that I've had with, I'm part of a group of neurointerventionalists that, in fact, we're meeting in Hawaii at the end of February, that work with venous stenosis and other, venous compression syndromes. And we are constantly talking about its mechanism of how it could potentially contribute to the dysautonomia symptoms of our complex patients. And again, we don't definitively know the answer. So I just want to be clear on that. But these are sort of these ideas that have been discussed, and we're actually working on some research ideas and trying to think of how we can do some clinical trials to support this. But I could say that when it's corrected, there is definitely improvement. So it seems to be at least one of the factors that contributes to dysautonomia. And then this is another great question. There are some really good questions.
Can I just jump in and add something to that?
There are so many questions though, and I was thinking them like, oh, we have to answer all of them.
To look at what you just said from a slightly different way that I think may be helpful for people to understand. This is entirely a plumbing issue, okay? It is. It's just all plumbing, right? And the image that might be helpful to think about is if you think of the compression, whether it's because of C1 pressing on a vessel or because of one artery is crossing another vein, it's like a dam, like dams in our rivers. And on one side of the dam, there's a lake. And on the other side, the water is rapidly traveling in turmoil, okay? That's the problem. That's the plumbing issue, that you have fluid sitting still on one side of the arrow, and on the other side, they're flowing too fast. And that combination completely screws up the normal hemodynamics, whether it's in the brain, around the heart, or in the abdomen, whether it's MALS, median arcuate ligament syndrome, or May-Turner syndrome, or CSF and fluid blood compression. It's a really important point because all of that then affects your autonomic nervous system and the blood pressure, heart rate stuff, which is so disabling for our patients.
Thank you, David. You constantly remind me that I'm never clear.
No, you are clear.
You always take what I say and then like break it down.
All right.
I apologize, but yes, that was well said. Okay. So, all right, here's another good question. First, they said, thanks for your excellent podcast, which we appreciate very much. We love doing our podcast. And we hope that that everyone else loves listening to us. So I love to hear thanks for the excellent podcast. She writes, I'm wondering what the long-term impacts of not properly treating my septat are. I understand the connective tissue disorder is degenerative due to the MCAS, but what other problems am I at risk for? Do I have an increased risk of cancer, dementia? I ask because my septat is fairly well managed currently with the help of lots of pharmaceuticals, but we believe my root cause to be Lyme. The treatment is expensive and invasive. If I knew that I was at risk for greater trouble down the road by not treating it, I'd be more likely to treat my underlying infection. Thanks. So that is an interesting question that I
Yeah.
often get asked a lot, but I'm sure that as much as I get asked it, you must get asked it all the time because you are infectious disease.
Yeah,
So
that's a big question.
it is a big question.
Um, I have a
I
couple
guess
of
we can
different.
start but so a person with Lyme disease. So if all the symptoms that are associated that with the Lyme diagnosis are, as she says, well managed, I guess the first, question to answer, I guess, is there still risk of the Lyme?
Well, I mean, the first question I would ask is if your septed presentation and the symptoms that that pathology is causing are all well controlled and you're feeling okay and able to manage life and live a reasonably quality life, what is it that makes you, this person, think that Lyme is still causing these problems? It's not self-evident. Even if you have Lyme, it's not self-evident to me. And translating that a different way, I am convinced, as are most of my colleagues in this complex illness world, they're not my mainstream colleagues, that Lyme, Borrelia is the cause of Lyme, Bartonella, and Babesia are pretty much the same type of organisms as the herpes family of organisms, HHV6, CMV, EBV. We get those viruses as children. They never leave our bodies. They're kept in a latent state by our immune system. But if there's a problem in immune surveillance, they can break out and reactivate. And I think it's the same picture with the tick-borne infections. And that implies that you can have a tick-borne infection that's either latent or of such a low burden, bacterial burden, that you don't need to worry about it. So I guess I'm questioning the first premise in this person's question, which is that the Lyme is causing her problem. I'm not sure of that. Conversely,
Yeah. Sorry.
if her physicians or his physicians, I forgot the gender of the person, are convinced that the Lyme is active and causing trouble, then yeah, I think it needs to be treated, because that would imply that if you could eradicate the tick-borne infection or lower its burden to a level that it's not significant, you might not need all those drugs and you might lead a normal life. So
do you think by having tested positive for Lyme, do you think that it puts you at greater risk for things, later on down in life? Like she was asking about cancer and dementia specifically.
I think it can, in the same way that so many other things can, which is the impact on the immune system.
Okay.
I've really come down to the point where, as far as I'm concerned, it's all about the immune system. It's
Yeah.
what is the Clinton phrase? It's your immune system, stupid. That's
It
the bottom line here. That there's another question here about mycoplasma. That's why we can't get rid of mycoplasma in some of our patients. It's the immune system. And therefore, if you have a disturbed or less than competent immune system, that system's job, among other things, is to do constant surveillance for cancer cells, for DNA damaged cells. And if it can't do its job, then yes, you have some increased risk. And it may be the same increased risk that you have as you get older. That's why older people get cancer more frequently. But I'm not saying it's the Lyme specifically. I'm suggesting it's the Lyme's impact on the immune system, which may be constantly trying to eradicate it and lead to T-cell exhaustion, things like that.
I think the concern is that there's been so much literature recently that has been showing the association with infection and neurodegenerative disorders. Of course, MS being the most recent, in the news with regards to an association with EBV, but also ALS, Alzheimer's. There has been, some really good research and some really interesting papers showing the correlation with infection and risk, at least risk of this disease, as the papers describe. No one goes as far as sort of saying conclusively or definitively that there's a clear correlation, though. If you actually read between the lines of some of the papers, I think it's actually fairly conclusive. And so that's very scary to a lot of people
Right.
because viruses are so ubiquitous, right? So what you say is so critical.
I want to make sure I'm not leaving the wrong impression here. I'm not saying to ignore infections or ignore Lyme, all right? What I'm saying is if you test your EBV and you have antibodies and your PCR, meaning your DNA is negative, and there's no reason, nothing in the antibody levels that is even remotely suggestive of reactivation, why would I treat that?
Right.
Right. And I'm saying the same thing about other infections, tick-borne infections. That doesn't mean I would ignore it at all. I mean, those of you who know me, I'm a pretty aggressive treater of tick-borne infections. But I don't think the simple presence of a marker means that it's an infection that's causing trouble. I would want more evidence, partly because of that, what this questioner said, which is that the treatment is difficult. It's a lot of drugs. We don't know how long to treat. I mean, it is an infectious disease nightmare.
Well, that's a really good question, and so I've read all the questions, so I think we're sort of overlapping and covering a few at the same time, which I love to do. I do think this idea of infection is terrifying for a lot of people because we're finding that there's a delayed onset of symptoms for many. So as we've often said, a lot of our patients come in with a history of, yeah, I had mononucleosis when I was in college. I was out for 4 months and, was bed bound, and it took me a long time to get back to baseline, but then I was fine for a bunch of years. And then all of a sudden things started to crop up, and then they become a septad type patient. And so if we decide that those, that let's just, again, just with the mononucleosis example, that is now a very important risk factor for delayed onset of some progressive chronic degenerative, in my opinion, disease. Like, what would we do differently about that mononucleosis at that time? I mean, so they're 19, right? So these are young, otherwise healthy people, or so they say. And we've often said that, the more that you ask questions about their childhood, we sort of find things. But regardless, they were otherwise healthy, went to college, got mononucleosis. I mean, how would it change how we treat? Like, to hopefully ward off what could potentially happen 10 years down the road, or, or more. So
really, really
yeah,
good.
I don't have the answer. I thought
It's a great question.
I
I mean,
was
the only answer I can give is I have seen some people come to me after they have had mono, but within weeks of their mono infection. And if they have a persistently positive DNA, PCR, I will put them on an antiviral. But I don't have evidence that that's necessarily going to reduce their risks later in life. And
right.
I mean, let's be clear, millions of people hundreds of millions of people have EBV, which causes mono, but they didn't have, quote, mono symptoms, right? And they're fine, right? Mm-hmm. You have it, I have it. Mm-hmm. And millions get mono and don't progress to ME/CFS. Right. So we can't, unfortunately, we almost have to wait to see how it plays out. And that's a horrible situation, but I don't know how else to approach it.
Well, I mean, there's a couple of thoughts that I've had along that. First, I've said to patients, because, our patients, a lot of them are either already, still young. Some of them have kids, and they ask me these questions, like, what happens when if my child were to have mononucleosis? And again, there are other infections. I just want to focus on the one example that I'm using, but what should I do? Because they're so scared about what will happen to their children, or, some of our patients, their grandchildren. Yeah. And so I often say, I don't really know. I do recommend treatment if indeed they develop mononucleosis, if they develop the symptoms of the EBV exposure. And then I say, and then in the interim, they really have to do a lot to just sort of support their immune system, without medications, of course, because there's no indication for meds. And I have my own personal, like, what I would do for the immune system, which is more along the lines of like lifestyle and certain supplements and, things that we've talked about, like sleep and nutrition and movement and all, and I try to guide them and give them those kinds of plans. And it's all in the vein of trying to help their immune system. But again, I have no evidence that will prevent, what they're hoping to prevent, of course. And, but I do think that I think we need to think about and of course we need long-term trials. We need to sort of know how we can ward off what the potential concerns can be from a delayed onset reaction to an infection that was, years earlier. And then the other thing that I do, though, is I do try to stratify risk. And so, I do a lot, and because now we formally work together, I do a lot of workup. I actually try to stratify, like, what genetic variants does this patient hold versus this patient. I do a lot of genetic analysis, and I try to find variants that are of genes of the immune system that could potentially put this person at risk. And if I find them, I'm a little bit more aggressive in trying to help their immune system and trying to support their immune system. I do lots of follow up to sort of, and I assess, like, well, how their innate system is working, how their adaptive system is working. And if I find any kind of aberration or trending in the wrong direction, I will sometimes recommend a certain medication for a short period of time just to sort of boost and support. And certainly if they get an infection, then I try to be all over it, or I just send them to you. Um, so, and I keep tabs on, like, all their organ systems, on, like, how it's working and how it's responding. And this is obviously a lot of work. It requires a lot of follow-up by the patients. And so that is a burden on them as well. And so, but I don't know any other way of doing it, because my fear, of course, especially with COVID now, is that we are set up for an epidemic of neurodegenerative disease from, we see so many long COVID patients, and that is my fear. So I do a workup in along that regard. I do a lot of different markers of neurodegeneration, especially if there's a large brain fog component. And, if I find anything that I just don't like, that just doesn't sit well with me, like, I will, be aggressive in terms of, like, not necessarily treatment at that point, but further workup, and then repeated workup at, like, certain time intervals. And, I think I get a little crazy, but I just want to try to rein in what I feel is ultimately an immune dysregulation, right? And sometimes it's hard to prove on the labs that we have, which, I always say about radiology, like, everyone relies on MRIs. The best we have right now is 3 Tesla, which is nothing. It shows a stroke and a tumor. Like, that's what it's good for. It doesn't show what we need to see for our patients.
Right.
The 7 Tesla and the 11 Teslas, which are now in just for research, and when they're available commercially, our games will change for our patients, right? So what we do for patients and what we know and what we can prove and what we can see objectively will be a completely different game. But until then, the 3 Teslas are only good at what conventional medicine already knows how to treat, right? Again, tumors and strokes. We know that. We know a lot about that stuff, because that's, especially in neurology, we know a lot about stroke. And vascular neurology is, like, a big deal. There's lots of studies. But, so similar to the labs, in my opinion, like, our assays are only as sensitive and as specific as they could be. And sometimes they're not all that good. I mean, the mast cell panel is a perfect example, right? So I think that, in time, I think things are going to improve and technology improves. And my hope is that we can be on top of that kind of technology and really use it to better, understand our patients and better stratify their risks is the ultimate goal, because I don't know how best to protect them until I could learn more, which is why I order all that I do, because I'm trying to get a bunch of data points. But again, it's a burden on the patients. And as you've said, the kits are often out of pocket. So it's a financial burden as well. So, anyway, but yeah, we need more answers to our questions. Maybe we should go to another patient's question. Yeah. So another one in the chat. It would be great to hear your perspectives on septat patients with early presentations of neuropsych issues, infection, PANS, PANDAS, POTS, depression, anxiety, sensory gating problems, OCD, others. I know a lot of patients don't like to conflate depression with their chronic illness, but for a number of us, illnesses began in childhood with insomnia, OCD, depression, and anxiety, and only escalated into full neuroimmune disease much later in life. And we've definitely addressed this before, David. I know that we have, because obviously neuropsych issues are very much a component of chronic illness, and it's because it's an immune dysregulation of the brain. Basically, and we call it autoimmune encephalopathy, autoimmune encephalitis. Sometimes it's limbic encephalitis. We don't often, we rarely find the autoantibodies that are conventionally associated with autoimmune encephalopathy, but that doesn't dissuade me in any way, because I always say about antibodies, we only look for what we know about.
Right.
We are constantly learning about new antibodies, autoantibodies. Like, I feel like every month I learn about a new autoantibody in neurology that has been discovered. So we only test for what we know about. And then antibodies themselves that, the titers wax and wane. And sometimes they're, very, very low and the assays aren't sensitive enough to pick them up. But regardless, the symptoms and the history are clear that this is related to a neuroinflammatory response. And I do believe that there are a lot of neuropsych issues associated. And I have a lot of adult patients who clearly, they give me a story from childhood and they clearly had pandas and it was never acknowledged or treated.
It's,
I wonder, like, if, again, back to that, what I was originally just rambling about, if we had treated that back then, like, where would they be today? Would they be better,
yeah, it's precisely the reason to start our histories at birth, as far as I'm concerned.
Yeah,
Right?
oh, for sure.
That so many patients, I mean, you've seen the same thing I have, where the patient will describe sudden onset of depression at 11 years old, or sudden, they don't necessarily label it, but OCD type behavior at 14 or at 7.
Mhm.
And that behavior is a problem within the family, but it's not pursued in any greater, with any bigger view of what pathology might be causing it. And then you start getting other hints of the problem, then that same kid has lots of allergies all of a sudden and sprains their ankle too often. And, it's almost like building a sandcastle, and little bits get bigger and bigger until finally the tip of the sandcastle peaks above and you can say, oh, well, now this patient's septad, but, it's too bad that we didn't know that when you were 14.
Right.
So, I do see this all the time, and I think it's a big part of the illness. And frankly, I think much of what's called psychiatry is really related to the things that you and I talk about, meaning immune dysfunction, autoimmune disease, infections, whether they're latent or active, obviously more of an issue if active. And I think psychiatry is coming around to that as well. If you read the psych literature and certainly talk to some of the psychiatrists, for example, in Mestemons, they would agree completely. I mean, there are papers that show deeply treatment-resistant depressed patients who've had everything, including ECT, get better with intravenous gamma globulin.
Mhm.
Come on, that's not, a
Yeah.
placebo.
Right. I mean,
So,
all you need to do is see one patient who has a classic autoimmune encephalopathy known as NMDA receptor encephalitis, right? So that's well documented, tons of literature about it, well known in neurology. When you see one of these patients, it's a neuropsych presentation. They usually have seizures associated, which I think is sometimes what neurologists will use as a marker of an autoimmune encephalopathy, but you don't have to have seizures.
right.
And also there are seizures that are not even picked up by EEGs because they're not on the cortical level, right? So they're sort of deeper in the brain. And there are brainstem seizures even. And in fact, brainstem seizures can be things like audiogenic seizures. And I think about all the auditory hallucinations that our patients describe to us, right? And then even seizures themselves can look differently than what they look like in the movies. I just did Dr. Bluestein's podcast, and I was actually talking about this, but they're not always like these generalized tonic-clonic rhythmic shaking movements. They could be, hallucinations. They could be like there are certain types that are just like vomiting. They're mostly common in children, but they're just vomiting, and these are seizures. There are changes in behaviors and changes in moods. There are just absence seizures, of course, which is just staring, right? So that and they don't respond, but then when they come back to, they just resume their activity that they were doing. So so there are all kinds of seizures that don't look like what people classically think of as these tonic-clonic kind of rhythmic movements. And so I think it's important to recognize that to use seizures as a marker of autoimmune encephalopathy as it's done in classic neurology is wrong. And so regardless, when you see these patients with, an autoimmune encephalopathy that is, classically seen in neurology, this is a neuropsych presentation. So it's no different than our patients. And so
it speaks to the bigger of this big problem that we encounter, we doctors like us encounter with complex illness, and other physicians too. Just because medicine doesn't have an explanation for something doesn't mean that something isn't happening.
right.
Just because we don't have a marker doesn't mean the pathology isn't occurring. And medical history, the history of medicine is filled with stories like that, where it can't be, you're nuts, you're an idiot, you're a wacko, you're a cowboy, you're just a crazy doctor. And then bam, suddenly that doctor gets the Nobel Prize because they hung on long enough, all right?
Yeah.
or finally an antibody is discovered. And mast cell activation syndrome for me is a perfect example.
Mhm.
Okay, there's I don't want to
Dr.
get too
Afrin deserves a Nobel Prize.
well, yes. I mean, if you think about
Agree.
it, without getting too deep, there's a so-called consensus 1 and consensus 2 of how to diagnose mast cell. Well, mainstream medicine says you can only do it this way, and anyone else who has a problem that might be mast cell, they're just nuts, not really a problem. Well, that's great. So I might as well just turn into go sailing or fishing. It means I can't be a doctor. That's
Right.
insane. Okay. And the problem is you and I and our colleagues deal with this on an everyday level. It's why my former colleagues, people, I mean, I'm still friendly, but they would roll their eyes at much of what I do because they'd say chronic fatigue syndrome, there's no test for that. So there is no chronic fatigue syndrome.
Right.
Or even long COVID. I mean, if you look at the world of long COVID clinics, most of them are still just saying, oh, you just need to do more exercise, get physical therapy, and see a cognitive behavioral therapist. Come on, that's just such garbage.
Yeah, I agree it's garbage, and it actually at this point makes me so angry.
Yes, yes,
Yeah.
it makes me
And
furious.
it happens on a still not as often, but on a still regular basis. Um, do you see many patients with hemiplegic migraines? Is this common in our patient population? That's an interesting question. So hemiplegic migraines is actually a channelopathy, and you can actually test for that gene variant. And interestingly, it's treated with acetazolamide, which is Diamox, which we treat a lot of things in our patient population with, mostly elevated intracranial pressure. But so is hemiplegic migraine specifically common in our patient population? I would not say so. And I would think that I would see a lot more of it as a neurologist if it were. But channelopathies, interestingly, I think are common in our patient population. And I only say this because I do a lot of consults with Dr. Richard Bowles, who's a geneticist and has a proprietary database that he does an analysis of raw data of the whole genome sequencing. And he's a channelopathy expert, and very often will find variants that will at least are consistent with or suggest that some of the patient's symptoms are related to an abnormal channel. And there are lots of channels, of course, that are on our cellular membranes. There are calcium, potassium, magnesium, sodium, and so on. And so it's not just one channel. There could be variants associated with different channels, and they can affect actually the movement of ions, frankly. And when we think about how our patients do well with fluid and electrolytes, I think that there's a large piece of me that wonders how much a channelopathy is also contributing to a lot of their symptoms. So while it doesn't present often as a hemiplegic migraine per se, and that there, I will say that's a familial kind of variant that we know about, and you could be tested for it if you happen to have hemiplegic migraines, and there is treatment for it, just so you know. But I think that channelopathies in general should be more discussed because I'm finding evidence of channelopathies in patients when we do this analysis, not infrequently. So that's an interesting question. So we addressed the mycoplasma. So PET scan, can it show neuroinflammation? So PET scans, it can show abnormal metabolism and the sort of how the brain is taking up oxygen and metabolizing not only the oxygen, but some of the nutrients. And so, it can be interpreted along the lines of neuroinflammation, though I would say that that's not a classic means of the use of PET scans. I've definitely been doing more and more PET scans with my long COVID patients because I am finding abnormal metabolism. The thought is that it's related to these microclots. So we've been doing also microclot testing and trying to correlate it with some PET scan findings and some other laboratory findings. So we're so behind on questions. Oh, look, someone wrote it was luck that the psychiatrist I saw knew to send me to Dr. Kaufman. That's nice. All right, back to the page. So we're running out of time. Okay, so for a patient with MCAS who needs a contrast CTA, CTV, what is your pre-post medication protocol? If she's already on over-the-counter H1, H2, quercetin, ketotifen, and will take small dose of lorazepam for sensory issues.
I think the first question is there any history of reaction to contrast?
Right, exactly. I think MCAS patients are so fearful of contrast. I mean, I find that when I'm trying to order imaging in general, even though they've never had a clear reaction to the contrast.
I guess the bigger question there is, and I don't know the answer, is there an increased risk of a contrast reaction in a mast cell patient? I have not seen that. And I don't do extra protection for those patients, but if they have a history, then yeah, I do lots of protection, including steroids.
Yeah, so do I. I mean, I do the same. I always ask if you have had a past response to contrast, and usually it's either I never had contrast or no, in which case I don't add anything because I agree. They seem to tolerate the contrast, even the gadolinium. Everyone's afraid of the gadolinium, of course, because of the concern of gadolinium toxicity. But and obviously the CTs are not gadolinium, though that's for the MRI. But I don't really add anything to it. I will have I will tell them that if they have a response that we could use steroids.
Yeah, I have not had any big problem with that.
Yeah. And then if chronic inflammation and or infection is a primary driver of MCAS and connective tissue destruction, should it be brought under control prior to CCI surgery? What would be your minimum criteria for an immune clearance prior to CCI surgery? So that's a really good question. And actually, we did implement an MCAS protocol intraoperatively and postoperatively at Mount Sinai for CCI surgery. Obviously, preoperatively, the thought is that whoever the doctor is that referred, whether it's, and certainly me or you, David, we are always managing the mast cell activity.
Yeah, I think there's a yes and a no to that question. The yes is yes, I would and try to optimize all other variables, meaning specifically mast cell activation, POTS, SIBO, and infection before the patient is referred or lands up getting invasive cervical traction. With the following exception, the no. If it's 100% bedbound patient, I will try to control those things, but I will have a lower threshold for saying, I can't fix this, you need surgery, meaning I think this is a CCI problem. But the general answer to that question is, yes, I would optimize as much as possible. I don't want to send a patient to Bolognese who's having hives all the time, or is not able to eat food because they're all causing reactions. That doesn't mean I'm successful all the time, but yes, I think as much control as possible.
And let's end with one final mycoplasma question. How many patients present with mycoplasma pneumonia, and what is the success rate with azithromycin? Is there another effective treatment such as IV antibiotics? I didn't mean to choose one that I have no idea about.
Yeah.
Sorry, David. So we're going to end with you.
So I have a group of patients with mycoplasma. I would not say it's a lot of patients, but it's definitely an issue. These are patients who are not clinically sick with mycoplasma. They don't have pneumonia. And for me, the definition is they have persistently positive IgM levels to the Mycoplasma bacteria. So not IgG. We all, or many of us have IgG. It's a very common bacteria. It's the IgM persistent positivity that I presume to indicate chronic, either latent and reactivating infection. Mycoplasma is considered one of these stealth infections. It is not well treated with antibiotics. It does not really have a true cell wall, which is what our antibiotics are designed to kill. That's how they kill. So it's really a problem. I've treated with azithromycin, doxycycline, and clarithromycin. The other antibiotics don't work. Rifampin doesn't work. I did a lot of research to see if we could figure out an excuse that it might work. Every piece of literature I looked at says it is hopelessly inactive against mycoplasma. So it's a huge problem. I've never actually given IV antibiotics, and I'm not sure there's much rationale to that. I mean, drugs like azithromycin have a huge ability to get an intracellular level. That's why they're such great drugs. And yet they don't, I have patients who just don't clear it. And I have other patients who clear their IgM and then 6 months later it's back again. So it's a big problem.
Thank you, David. All right. Well, thank you everyone for joining us today on our live. We really appreciate your support. We appreciate you being subscribers. And this will be posted in a couple of weeks. The next episode that is dropping is our conversation about headaches. But then this one will be posted the week after that. So again, thanks for joining us today and have a great rest of your weekend.